Professor Dr. C.P. Vijayan, Honorable Vice Chancellor, and Professor Dr. Shaji K.S., in the search to take their seats on the stage.
Now we will have Kerala University of Health Sciences Oration by Professor Vikram Patel. I request Professor K.S. Shaji to introduce the orator.
Thank you, Vikram, for being here. Vikram Patel is the Paul Farmer Professor and Chair of the Department of Global Health and Social Medicine at Harvard Medical School. He holds an honorary professorship in Harvard Chan School of Public Health, London School of Hygiene and Tropical Medicine. His work has focused on burden of mental illness and use of community resources for prevention and treatment of mental health issues. He has a number of publications, more than 400 peer-reviewed articles, many books, chapters, and he is ranked among the top 0.05% of scientists, according to Clarivate. He co-leads the Lancet Commission on Global Mental Health and Sustainable Development. And for the undergraduate trainees, he is one person who took up research as a career from very early days after his MBBS. So I'll not, you can look his CV and details on the net. So over to you, Vikram. Thank you very much.
Thank you, Dr. Shaji, and thank you to the Vice Chancellor and the leadership of KUHS for the honor of delivering the oration today. It's a real pleasure to be here with the deans and the leaders of so many of the medical, nursing, pharmacy, and allied science colleges in Kerala, and to see how much effort is being placed to integrate a culture of inquiry, a culture of reflection, a culture of publication within the undergraduate curricula. Certainly, my own memory of being a medical student in Mumbai back in the 1980s, we were focused almost entirely on learning clinical skills, which of course is why most of us join one of these colleges. But I do believe that we had a missed opportunity to also offer undergraduate students the opportunity for those who had an aptitude to learn research skills. So I wanted to really spend this opportunity to share with you how powerful research that is done in our country and indeed in our region of South Asia can not only transform healthcare policy and practice within the region, but also in fact transform the way the world views the innovations that come from our region. And we often think of innovations in a highly technological sense. When you hear the word innovation, the first thing that comes to your mind is, something that's happening in a laboratory or something that's happening in a company that is developing new technologies. But I'm going to suggest to you provocatively that the single most important innovation that has come from South Asia and that is transforming global health is actually not a sophisticated innovation that comes from the private sector or from, but in fact it's an innovation that is entirely related to a grassroots approach towards the addressing of health problems. So that's what I'm going to focus on today. I want to, as many of you know, I'm a psychiatrist, and while most of my work has been devoted to the area of mental health, I've also been very deeply involved in other areas of health in India, which I'll touch upon later. But most of my talk is going to refer to the work on mental health in South Asia in order to just give you a sense of why I believe that these grassroots actions are actually the most innovative, transformative of all health interventions that have emerged from India. So let me start with this, the National Mental Health Survey. This was and is the largest epidemiological study of the prevalence and the response to mental health conditions in adults ever undertaken in India. The study was coordinated by NIMHANS, but in fact it was commissioned by the Ministry of Health and Family Welfare. I served on the technical advisory group of this first survey, and I know now there is a second wave that is being currently planned. So when the report was published a few years ago, obviously being an epidemiological study, the most important question that we might be interested to ask is, what is the prevalence of mental health conditions, diagnosable mental health conditions, in this random population sample of over 30,000 adults drawn from across India's different states? It turns out that the number is approximately 100 million. Let's pause and reflect on this number for a little moment. 100 million adults, according to the National Mental Health Survey of India, are currently experiencing. This is not a lifetime prevalence, it's a current prevalence of one or another form of a mental health condition, which of course also includes substance use conditions. But I want to draw on two other facts that the National Mental Health Survey actually illustrates, which to me are actually even more important than the absolute number of people who are living with a mental health condition. The first important fact is that these conditions are not equitably distributed in the population. What does this mean? As you can see on this slide, I'm showing you the prevalence of one of the most common mental health conditions, depression, according to how wealthy or poor you might be in that sample. And what's very clear from this slide is that the richer you are, the lower is your prevalence of depression. And what this demonstrates is something that is true of most health conditions, is that social disadvantage, in this case in the form of poverty, is strongly associated with poor health outcomes. The point I'm making here is that we haven't fully acknowledged that in the mental health space, this is also true. We freely acknowledge, for example, that maternal mortality or tuberculosis is more common amongst the poor. Here is evidence from the National Mental Health Survey that that inequity is also true for the most common mental health conditions. And I've had to show you psychosis, for example, you will also see a very similar pattern. So that's the first additional number that we have to consider, or metric that we have to consider from the National Mental Health Survey. And the second one is, what is the proportion of people with a mental disorder who are currently or have recently received care from the healthcare system? This does not mean any kind of care, because of course many of us will go to our neighbors, will go to our religious places. This is specifically about the allopathic care system. And this is a staggering set of numbers. Essentially, in a nutshell, between 75 to 85% of people in the national sample have received no care at all in the previous 12 months. None. Which means that if you flip it the other way, that only 10 to 15% of people actually receive care. And we're not even talking about the quality of care. We're only talking about having access to a healthcare facility. And I think, as all of you know, simply going to a facility doesn't mean that you're going to get the care you need. This is, in my mind, probably the largest unmet need for healthcare for any health condition in this country. And for me, this is the single most important metric that we, as people who are concerned with public health and community medicine in India, must be focused on. Now, the immediate question that comes to our minds, if we had to ask, for example, mental health professionals, or we had to ask policymakers, why is there such a massive unmet need for care? The standard response is going to be because we don't have enough mental health professionals. And that is absolutely true. In this slide, you can see the most populous countries of the world, and you will see them labeled there. And you'll see the population of those countries on the x-axis, and on the y-axis, you will see one cadre of mental health professionals, that is psychiatrists. And I'm going to compare two countries here, two countries that I live and work in and I'm familiar with, the United States and India, in those red circles. And what's very evident here is that when you adjust per capita, that India has a minuscule number of psychiatrists compared to the United States. So the question to ask us is, does this massive amount of psychiatrists actually create a different outcome on the population when it comes to mental health metrics in the US? Because I guess if you really took the position that we need more mental health professionals as the only strategy to address the burden of mental health problems in the population, then the United States should be doing really, really well. In fact, not only does the United States have a very large number of mental health professionals, and by the way, that's only psychiatrists. If I add psychologists, the number is astronomical. I mean, there is, India would not even be on that chart if I had to include psychologists. But it's not just human resources that the United States does very well in. It's also the amount of money that the US is spending on mental health care. Contrary to what most people in the United States think, that we in the US don't spend enough on mental health. In fact, as this chart shows, the US spends more on mental health care than on any other group of health conditions, including, in fact, extremely expensive health conditions, such as, for example, cancer. So, the US spent a lot of money. A lot of it is spent on mental health professionals working in hospitals. What has been the impact of this vast amount of money and this huge mental health specialist resource? Well, certainly at the population level, none at all. On this slide, you can see that the prevalence of the most common mental health condition, that is depression, over the last 20-odd years has not only not changed, but in fact, in the youngest Americans, it's gone up by nearly 30% during this period. Typically, if you had to show you a slide of, say, cardiovascular disease mortality, you would find a steep decline over this period. Even some of the untreatable conditions, like Alzheimer's disease, are also showing a decline. But when it comes to mental health conditions, there is not only no decline, but in fact, there is a worsening of trends. The most hard metric, of course, in health, in terms of population burden, is mortality. The US is witnessing currently the worst increase in mortality associated with behavioral health conditions in modern history. As you can see here, these are called the deaths of despair, a term that was coined by the economist Angus Deaton, who received the Nobel Prize in economics for this exact work, where he and his collaborators demonstrated that since the year 2000, the numbers of people dying of suicide and substance use-related mortality, which they clump together as the deaths of despair, has risen astronomically. And in fact, these conditions today are the number one cause of death in Americans between the ages of 14 and 15. In other words, if you're a young or middle-aged American, the chances of mortality are the highest because of a mental health or substance use condition. In spite of the huge number of beds compared to India for sure, and all the services in the United States, tonight, more people with a psychotic or a substance use condition will sleep in a prison than they will in any form of healing or in their own homes. In fact, the situation is so bleak that even the science that the US so generously funds has produced nothing new in the last 20 years. These are the words taken directly from a book from my dear friend Tom Insel, who is a biological psychiatrist who led the National Institute for Mental Health, which is the world's largest mental health research funding body. And I think the words speak for themselves. So it turns out that the US spends more on psychiatrists. It spends more on mental health care. It spends more on mental health research than any nation in the world. In fact, probably all developing nations put together in one basket is less than the US. And every single metric to do with mental health in the population has worsened over the same period. So the real question is that why is it that countries around the world, including the wealthiest countries, have failed to address the burden of mental health problems in their communities, in their populations, in an equitable way? Mind you, this is only true of mental health. This is not true of cancer. This is not true of cardiovascular disease. This is not true of infectious disease. It is only the case for mental health. And I think we do need to sit and ask ourselves the question, what is it about the biomedical paradigm that has succeeded so well for many other health groups, but not for them. This is an issue that a group of us were invited by Richard Morton, the editor of the Lancet, to examine what might be the reasons for failure globally in terms of mental health. We put together this article as a health policy article in the Lancet in 2023, and I'm not going to go into the details of what we found because there are many things in that piece that really speak to why we have failed globally on the mental health crisis, but really reflect on the cause. What is the singular cause that we identify? And that is, quite simply, that in the mental health field, we have blindly adopted a very narrow. Lastly, our focus psychiatrists tends to be on the symptom checklists that we are so concerned about in the diagnostic systems. This is not what most people with mental health problems are concerned about. They're mostly concerned about their social well-being, their social or spiritual health. And so there is a complete mismatch between what the biomedical system is targeting and what the person with mental health problems is actually wanting. So I want to now turn to a very different story, and that is, how has South Asia innovated a very different, not a top-down biomedical, but a bottom-up, grassroots approach towards addressing health problems in this region? And what can we in the mental health field learn from the successes of that grassroots approach? Back in the early 1990s, when I was planning my return to India, I was in Britain completing my psychiatry training, and then I was in Zimbabwe, where I worked for 2 years doing a doctorate on mental health problems in primary care. I was introduced to this book that was published actually around in the 70s, maybe the 80s, I can't remember the exact date. It was produced by the Foundation for Research in Community Health, which at the time was one of the leading research centers. It was an NGO based in India. And the book was edited, amongst others, by one of India's great community health practitioners, Professor Antia, who interestingly did not go to the community medicine program. He was actually a plastic surgeon. And I was a little baffled, what is a plastic surgeon writing about people's health and people's hands? Seems like such an improbable combination, especially when you think of what plastic surgeons do today. But it turns out that, of course, back then, plastic surgery was not about making people more beautiful. It was about actually helping people with leprosy who had terrible deformities actually address those deformities and be included in their villages and in their communities. And he used to work with these. In those days, only some of us were remember when leprosy was still a horrendous, stigmatizing condition. People with leprosy were sent outside their village. They would actually live in these separate settlements that were outside the main village. And so Professor Antia began to work with not just the persons with leprosy by surgically treating their deformities, but also with the communities themselves, to educate them that how the new antimicrobials were in fact making leprosy a non-contagious condition, etc., etc. You know the story. It's one of the great success stories, of course, of medicine. In the book, I read a number, it was an edited volume, of innovations of grassroots action on community health in India. And one particular story caught my eye and has remained part of my own story for the last 30 years. And that story is best exemplified, by this particular woman. This is a lady called Anjana, and she lives and works in one of the villages in the district of Gadchiroli, which is in the center of India. So one of those stories was about this young doctor couple, Rani and Abhay Bam, had gone to the United States after clearing medical school in India, back when there were no masters in public medical in India. So they had gone to Johns Hopkins, and unlike most of their peers who would have gone to the US and done cardiovascular surgery or something and stayed there, they actually went to do public health, which back in the 70s or 80s was, what is public health? They did that and they returned to India and they set up an NGO in Gadchiroli called Search. And where they decided to devote their life to helping the tribal people who dominated in that area address their health needs. Very quickly, they discovered that the single most important health need was newborn mortality. The newborn mortality rates were astronomical. And the reason, of course, newborns were dying as they studied newborn mortality was primarily due to preventable causes of death, especially pneumonia and various forms of sepsis. A lot of that was related to home-based delivery. Now, no pediatrician. They try to get some pediatricians to come to Gadchiroli. I know Rani very well. I've been there almost like a pilgrimage to go there. They try to get pediatricians to come, and nobody's going to go. This is back in the 70s and 80s. Nobody was going to go to this remote part of India after becoming a pediatrician. So what could they do? They were watching babies die, and they decided that they would, in fact, work with local women in those villages, and with them design an intervention that would actually give them the skills to detect newborn pneumonia and sepsis. Using whatever simple technologies, I use the word technology here deliberately, whatever simple technologies, like what? Like a metronome. What do you use a metronome for? To count respiratory rates. Such simple homegrown ideas. They use these. They also thought of ways in which they could train these lay women in the community, like Anjana, to actually deliver gentamicin, other antibiotics for those babies who they found potentially having. When they started doing this work, there were howls of protest from pediatricians and neonatologists in places like Mumbai. It said that the moms were really doing witchcraft kind of medicine. They had to be completely stopped. Clearly, it was obvious that there was a lot of opposition from the medical sector. When asked, including the World Health Organization, they completely rejected this approach. Instead, the approach that they were being recommended was that of building NICUs all over these rural areas. Neonatal intensive care units back in the 70s and 80s. You can understand how absurd this was. So what Rani and Abhay did was they applied science. They agreed. It was important really to address this concern that people had that by giving women like Anjana all of these techniques and tools, maybe they were harming these newborn babies. Not doing good, on the opposite. They were harming them. So to their credit, in this incredibly remote part of the country, with no backing from any medical school, not a single rupee from the government or from any international agency, they conducted a cluster randomized controlled trial. And this paper that was published in the Lancet, at that time probably the only paper ever that came from a rural community to be published in the Lancet, has now been ranked as one of the 10 most influential papers in all of medicine history. They were able to demonstrate that in a cluster randomized controlled trial, the newborn mortality plummeted by more than 40% in the villages in which women like Anjana were working. In fact, maternal mortality also fell in those villages because, of course, those frontline workers were also motivating women to go to the Search hospital to have their babies in institutions rather than at home. What a remarkable experiment this is, and shows you the power of grassroots-led action, marrying high-quality science, high quality that it also got published in the world's best medical journal. Now, of course, you can argue that a single trial does not change policy and practice. And indeed, when this paper was published, it shook up pediatric and maternal specialty environments. But people refused to accept it, including ICMR. But ICMR, with all credit to the leadership of ICMR decided that, quite right, that they needed to fund replications. And they did fund replications. Not just in India, but other agencies also funded replications in countries like Kenya and Bangladesh. I'll come to where we are today. This original trial, friends, was the origin of what we now call the ashram. If you have to track the history of the ashram, you will see that the origin story comes from this kind of innovation. They were not the only people, there were many others, the Aravis, the Champion, and so on. But this is the kind of grassroots innovation that led to the emergence of the ashram. And indeed, today, not only does the Indian government embrace this idea in the National Health Mission, more than 1 million ashras and many other community has been rolled out, but also the World Health Organization has changed its policies around reducing newborn and maternal mortality, so that in most parts of sub-Saharan Africa today, you will also see the model that has emerged from India has transformed maternal and newborn health around the world. So I saw this incredible story. It was deeply inspired, as a psychiatrist, a young psychiatrist returning to India and seeing the fact that almost nobody back then received any form of care. And there was not just a supply side barrier back then. We'd ignored the demand side barrier. Nobody wanted to see psychiatrists because of the stigma that was attached to that. And so it was clear to me that we needed to look at grassroots solutions. I was deeply inspired by the work that Rani and Abhay Bhag were doing. I went and talked to them. I spent time in search. And I decided then that let me apply the same grassroots methods to the design of mental health interventions with the explicit goal that those interventions should be delivered by people like Anjana in community settings. I'm going to cut straight then to one example of such an intervention. And that is a brief intervention built around the science of what's called behavioral activation that we designed for delivery in primary healthcare settings for people with severe depression. Importantly, just like the home-based newborn care model, it could be delivered by anyone. It did not require you to have a mental health professional background to deliver. This program was funded by the Wellcome Trust. I was living in Goa, and I have been, that's where my primary home is, since 1995. And I have founded an NGO called Sangat, which actually led this whole program in partnership with the Director of Health Services of the government of Goa. And the whole program was funded by the Wellcome Trust. At that time, I also had an affiliation with the London School of IT and Job. Before I show you the results, I wanted to just show you a brief video that illustrates the simplicity of the approach that this intervention actually embraced.
पहिले म्हाका खूप त्रास आहे 2 वर्ष झाली तकली दुखा आणि चक्कर येयल्यासारखीच आहे डेली तकली दुखा डेली घरातले कसले काम जायना जाय भिजून रावा दिसभर भुरग्यांक सुद्दां मी लागी घेयना जाय कित्याक घरातले करिना जाय
म्हाका खूप त्रास करता घरा देव आनी तेजी बायलूय शिकयता आनी म्हाका खूब टेंशन जाता तकलेन आनी हांव बरें नासता म्हाका जेवपाची बीन याद उरना आनी कितें खावचें कितें काम करचें अशें म्हाका दिसत ना आनी भुरग्यांकूय हांव केन्नाच सारकें वाडिनाशिल्लें कांय करिनाशिल्लें तांकां एक कितें करप आनी कितें घातलें आनी घालप आनी टायमूच म्हाका असो बसोनूच हांवें काडप म्हाका खूब टेंशन जाता.
With depression, we've developed a very specific treatment called the Healthy Activity Program. This is a treatment that's based on the concept that when people become depressed, they stop doing activities that they typically do. For example, there may be social withdrawal, they may not be able to keep up with their work demands, they may stop doing pleasurable activities like watching TV, reading, etc. The less they do, the worse they're likely to feel. So the Healthy Activity Program is delivered over about 6 to 8 sessions. So the main focus of the initial sessions is to get patients to become activated, to start doing things that we know will help them feel better.
कितें काम कर म्हणजे मागीर थंय रोंपो लायलो मातशें अशें भोंवंक वचूंक लागलें जावं काटयां हाडूंक लागलें शेतान मातशें वचूंक लागलें आनी कितें भाजी पालो घरा कडेन रोवंक लागलें आनी तितूर मात मागीर म्हाका म्हयन्यान करून म्हाका एक 9 म्हयन्यांनी सारकें पूर्ण तकली म्हाजी शांत बरी जाली. पयलीं तेणी 5 मिनटां कुळागरां वचून काम कर म्हणलें. मागीर तेणी म्हाका 10 मिनटां दिलीं. मागीर 15 मिनटां दिलीं. मागीर म्हाका तें काम बरें जाता अशें दिसलें. हांवें 5 मिनटां 2 मिनटां वाडोवन करप. मागीर म्हाजी भुरगीं येतालीं मदत करून. आनी इतल्यान म्हाजें आतां कुळागर निव्वळ आसा आनी म्हाजें कामच चालू बरीं जाता. आनी म्हाका आतां वखद सुद्दां नाका. बरी जाली तितूंतल्यान आनी बरी आसा हांव सामकी.
आनी आतां म्हाका खूब बरें दिसता. जशी तकली जास्त दुखना, केन्ना अशें चुकोन दुखता. बेगीन उठपाचें, भुरग्यांक शाळेक धाडपाचें जाता, त्रास जायना. तकली बी दुखना आदल्या सारकी.
So let me show you now the results of the trial. In the original trial, we recruited nearly 500 individuals from 10 primary health centers. They had severe depression, not mild to moderate, but only the severe form. And we deliberately chosen that group because this is, of course, the most unwell. Now, what you can see here at baseline, everybody was depressed. 3 months, that is about a few weeks after the last session of treatment, those who were in the treatment arm, 2/3 have recovered or remitted. At 12-month follow-up, similarly, that 2/3 did well. And 5 years later, an independent team led by Professor Abhijit Banerjee, who many of you will know is a Nobel Prize-winning economist, who was interested to investigate the economic benefits of treating depression. Their team followed up these trial cohorts 5 years later and continued to show that 2/3 remained well. Of course, this also means 1/3 didn't, and I'll come back to the point. But it is important to point out that 2/3 of people with the most severe form of depression not only responded to just about 2.5 hours of talk time with a layperson, but they stayed well for 5 whole years after. Actually, Sangat as a pioneering organization has been working, adopting this model, which we call Sundar, and I'll just tell you about it in a moment, what Sundar stands for. And here you can see the range of different randomized control trials that Sangat has been leading, covering the whole range of mental health issues from prevention and promotion, such as, for example, working in school environments. Bihar, the largest cluster randomized control trial ever conducted, actually in schools in India, demonstrating how transforming the social environment of schools can actually lead to dramatic improvements in mental health. All the way from prevention and promotion through to the care of people living with serious enduring conditions like autism and schizophrenia, the full gamut. And all of that based on some foundational principles of leveraging the resources that communities have rather than trying to wait and asking for resources that are currently unavailable or unaffordable. Importantly, you'll also have noticed that all of those papers that I showed have been published in journals like Lancet and JAMA, 2 of the top medical journals in the world. This is the kind of breakdown of ingredients. I mean, I created this acronym. Of course, it doesn't fit so well typically, but Sundar is a lovely word. It means, of course, pretty or beautiful in Hindi. What are the key ingredients of these interventions? And these are primarily really derived from the original innovative work that was done by grassroots pioneers like the Bums. Simplify the language, strip away the jargon that psychiatry and medicine has wrapped itself in, almost as a way to exclude everyone else from that field. Unpack the interventions into smaller pieces. Psychotherapy has become so ridiculously complicated that it requires years for anyone to learn how to practice. So we've shown repeatedly, time and time again, that identifying the active ingredients of these complex behavioral interventions allow those treatments to then be delivered by whichever human resources are available, and allows the specialists people like myself to actually perform different roles, work at the top of our license, as it were, to train, to supervise, and provide referral pathways. Remember the 1/3 who did not respond. It is that 1/3 that needs to actually be seen by a psychiatrist or a psychologist. This is the philosophy, which is gone into a book. I actually wrote the first edition of this book back in 2003, before the first trial actually existed. I was able now, on the back of a very large body of evidence that is transforming our way of thinking about mental health care in community settings, to write the second edition of the book that was based on much of the science that has emerged from around the world now, that has totally transformed the way that we think about how grassroots engagement can change the way our mental health care systems respond. By the way, I've been speaking to some of you. I know that Kerala is a place where one of the major priorities is elderly care. I can assure you that if we adopt a hospital-centric, specialist-led biomedical approach to elderly care, we will fail just the same way that we have failed with elderly care in the United States. Not only has elderly care in the United States become unaffordable, it's bankrupting the healthcare system, and the quality of care that most elderly people are receiving is extremely variable. It's really important for us in India to not copy that system, because it is a failed system. Because elderly people also have a complex array of conditions that do not fit neatly into a single diagnosis biomarker. This kind of approach, of course, has a long history now, and my dear friend, my late colleague, Professor Paul Farmer, wrote this extremely important piece demonstrating how frontline workers, community health workers, use this term accompagnateurs, which is a French word that he actually derived from his work in Haiti with people with TB and HIV. And I'll just quote Paul, what accompaniment means. It means to accompany someone is to go somewhere with him or her, to break bread together, and to be present on a journey with no beginning and end. And I think this is a very powerful evocation of what ashras do. It's a very powerful evocation of what community health workers are supposed to do, to accompany individuals, their households, and their communities, rather than what the medical system does, which is to treat episodes of sickness. Friends, I want to end by just saying a few words of how this innovative science is transforming global health. This science is actually probably the most exciting science that has emerged from the mental health field in the last 20 years. To the extent that it's now being embraced by a range of global agencies, and on this slide you can see the covers of reports from the World Bank, the World Health Organization, which now completely embrace this implementation science and call for the scaling up of these approaches in countries around the world. And this is not just in developing countries, if I use that old-fashioned term, or low and middle-income countries, but in fact also in the wealthiest countries. This is a document published by the RAND Corporation as part of a major initiative in New York City, which is seeking to actually transform mental health care in the world's best city. We will see that they adopt exactly the same language of grassroots action. In fact, some of that work is now also transforming global health. Here are 5 examples of science innovations that have come from Sangha. They span a range of issues. For example, the DEEP tool is a tool that has been designed to be used on a smartphone by frontline workers and ultimately parents to assess cognitive development in preschool children, because there is currently no way of assessing brain development in children until they start first time. It's too late often to do anything. So this tool was designed to empower frontline workers and parents to actually get inside the brains of children in much the same way that a weight scale allows us to actually measure the weight of a child. This tool has now been not only validated, but is now being implemented in parts of Africa, South America. Similarly, there are many other interventions that have now been exported, as it were. Again, I think an example of how innovations in India are so attractive that they're being embraced by countries with the most sophisticated technologies. Examples of the healthy activity program, which I showed you a moment ago. In the United States right now, this manualized treatment has been adapted to delivery in the US. And at the moment, there is a large scale-up of this treatment happening in the state of Texas in partnership with multiple different hospitals as well as community-based agencies, including, I met one of you over the pre-break who said that they were a priest. One of the most exciting sectors that we're working with in the US is in fact with churches. Texas is a very deeply religious part of the US, and we now have a very exciting partnership with 32 churches, mostly working with Hispanic or immigrants from Central America who speak Spanish. We're using the power of faith to actually motivate members of the congregation to learn behavioral activation, the healthy activity program, and to deliver it to people in their communities with supervision and support from the healthcare system. And this idea is not only a grassroots idea, but it's also now attracting significant amounts of funding interest from science agencies like the NIH. The second example, again, a large research study that demonstrates the impact that the activity programs globally is the Summit trial. This is one of the largest trials for perinatal depression conducted in the world. More than 1,000 others with depression identified from 3 major hospital systems in Toronto, Chicago, Chapel Hill. The treatment, the healthy activity program, taken from India, adapted from others in North America, paper just published in Nature Medicine. You can see the title, Dasha. That's actually the strategy of taking these interventions and having them delivered. My point is that we are the laboratory of some of the most creative innovations in public health and clinical care. That is not coming from the private sector, it's not coming at laboratory science, but it is coming. What this innovation is showing us is ways of redefining mental health care, and I would argue this is also true of NCD care, elderly care, targeted care. Of course, Kerala is one of the great examples of innovations in targeted care. First of all, by redefining what is mental health. Moving away from this very narrow idea that it's a prescription. Who is going to have, where is this going to be provided? Moving away from the idea that this has to be provided in a clinic or a hospital. Who is going to be the provider? Moving away from the idea that it can only be a psychiatrist or a psychologist or a social worker. And the how. Typically, the how is illustrated in this slide here, which is that you build a healthcare system which puts at the center of the system the person with the mental health condition and their family. And they scaffold it around that by frontline work. It's a generic term. It can be anyone. In the United States, for example, our frontline workers are just members of faith congregations. Frontline workers can be nurses, it can be social workers, it can be community health. A lot of our work in India is in fact with community health officers, ASHAs, working in primary health system of the government. But the key here is that you have a scaffolding of the person in the middle, and then you have a collaborative approach with the primary healthcare system for those individuals who need primary care doctor inputs, people who do need, for example, antidepressant medication. And then for more serious mental illness, you have a liaison with the more specialized psychiatric facilities in which is the hospital. But the heart really here is the community. Without that scaffolding of the community's support, we will not be able to shift the needle of the burden of mental health problems. So my last couple of slides, just to round up, friends, what I hope I can leave you with are some key messages on reimagining care. The first important message is that we need to move away from a narrow diagnosis-based focus that has dominated the mental health field. Diagnosis is important, but it is insufficient to actually address mental health problems. What we need to be thinking about is how do we address the person's felt needs. And most commonly, those needs typically involve their lived environment, social needs. We need to organize care, moving away from a one-size-fits-all model that either you receive psychiatric care or not, to recognize that the right approach for all kinds, from diabetes to depression, is a step care model. Everyone should receive a low-intensity, community-based psychosocial intervention, which acts as a filter to identify those who need more specialized medical interventions, pharmacological interventions, potentially in rare instances. In order to do this, we need to empower our communities with the knowledge, with skills, with resources, and hopefully also with referral pathways that are well institutionalized, so that there can be a seamless flow for people with chronic conditions to move up. Remember, with mental health conditions, those who need admission, when they are discharged, they need continuing care as well. So that referral pathways have to operate in both directions. And lastly, we need to ensure accountability and equity. This is extremely important. Because as you've seen at the beginning of my presentation, most health problems, including mental health problems, are inequitably distributed in the population. And this means that the goal of our healthcare system shouldn't just be improving the national average. That's important, but it is insufficient at that. What we also should be focusing on is to reduce the inequalities that actually are so common in India across all health problems. This is also true of mental health problems. My last slide, and this is, I know Dr. Shah did tell me that this is of course a UG research aid. So I wanted to maybe just end by sharing a few lessons that I take away from my 30 years of working in community health in India. What might be the research lessons or paradigms? Many of us, when we're doing research training, we think of this is largely as a technical, technical skill. Therefore, this is extremely important. We cannot do research without those technical skills, sample size calculation, and so on and so forth. Many of you will be familiar with that through the course of your life. But I think there are some more profound human skills, which I take away from my own experience. I think it's important for us to focus on the problems that our communities experience. This is one lesson I learned from the bound in my time in search, is how important it was to them not to just come up with their own research priorities, sitting in their office, but actually to engage with the communities they serve, understand better what they want to concerned about, and to then frame those concerns in scientific terms to evolve research questions that they found experiments. I've already mentioned equity, but in addition, I'd like to also mention scalability. We in the mental health field have been singularly the worst examples of thinking about scalability in our research and science, particularly when it comes to interventions. The classic problem in the mental health field, and this is also true of other chronic diseases, is that we design interventions for hospitals, and then we try to figure out how to deliver them in real world community settings. The design process has to be exactly wrong. Start with us. What can be designed in communities, in the hands of frontline workers, rather than the office, which has dominated? Psychotherapy is a very good example of that. They were designed, delivered in university hospital settings, people with extraordinarily complex mental health conditions by highly trained. And then we start scratching our head and saying, how do we transform this innovation to real world impact? Of course, it's extremely difficult to remodel a house that is already been built, as opposed to building a house on a we must break away from disciplinary silos. My own work learned so much from, for example, the social sciences, particularly anthropology, which is a central social science for my work, but also economics, for example. And so it's really important to break away from the very narrow research silos that many of us have. In fact, even within the medical field, like I showed you, my inspiration for my work comes not from psychiatry, It actually comes from maternal and child, comes from HIV/AIDS. So by actually collaborating with and learning from other disciplines, both scientific disciplines, but also within medicine, other disciplines of medical specialism is essential to really being a successful community researcher. And lastly, partner. As Paul Farmer said, the best, there's nothing in the world that you can do that is going to be transformative that doesn't involve partners. And partnership means stepping out of institutions, which I believe in India has been a huge problem. That has changed now. Many institutions rarely found themselves partnering with NGOs, for example. And I believe that that relationship is central because NGOs are, civil society is, often much more deeply embedded in communities than medical students are. And so I would urge those of you, and many of you are in leadership roles in medical schools, nursing colleges, and so on in this room, is look at civil society as a partner. A partner that brings a lot of value to you, as opposed to someone who is just often, hierarchically less powerful. In fact, the lived experience of the communities is one of the most important experiences in the world, especially the lived experience of people who have spent decades listening to, learning from, and embracing what it can mean into thinking about what kind of research do they really want to see. So with that, thank you very much, and thank you for your patience, and once again, thank you, Shaji, and thank you to the leaders.